Hi, my name is Elise Hart, and I was last year's emergency ultrasound fellow here working under Dr. Mike Lambert. And today I'm going to be talking to you about ultrasound guided peripheral IV access. So I have no disclosures. And I know I'm preaching to the choir, to you guys who are here, who have already bought into this, but just as a reminder, here are a few of the indications that we might pull out the ultrasound to help us in getting access in a patient. For one, patients who are pretty obese or have deep vessels due to edema can definitely be helpful, as we're not able to easily visualize them subcutaneously or even feel them for that matter. Additionally, you may have pretty limited targets. You may really need to get that AC line for a CTA, or the patient may have limb precautions that only gives you a very limited number of shots, so you want to take good advantage of them. The patients may have pretty tortuous vessels running under the skin, or they may be pretty scarred down from multiple prior IV access attempts, whether that's from a history of IV drug use or frequent use of the healthcare system. And then additionally, our shocky patients for hemorrhage or sepsis who are going to be pretty clamped down, or hypovolemic in general, just may have pretty small vessels that are pretty difficult to target. Likewise, pediatric patients, this can be helpful in who have small vessels. And basically any other patient who's considered a classic hard stick, so that person who you're going for a 24 gauge in the right toe is probably somebody who it might be helpful to take a look before we start poking at the few targets that we do have. Before we go further, I just want to take a moment to touch on standard precautions for this procedure. It's not well studied, but there are a range of options available to us in terms of maintaining sterility during this procedure, ranging from a sterile probe covers used for central venous line procedures to covering it with a sterile or non-sterile glove in a pinch, or covering it with an adhesive barrier like a tegaderm. And in terms of gel, we have sterile gel options, such as the packets used in the central line sterile probe cover kits, as well as Surgilube, which is an option, although it's small volume and is a little bit thinner, so a little bit harder to work with, as well as our regular gel, although that is not sterile. And there aren't great guidelines for this, but ACEP, the American College of Emergency Physicians, does recommend that probes used for percutaneous procedures be covered with single-use protective covers, and that sterile gel be used. And the minimum that this would involve essentially is using a sterile adhesive barrier like a tegaderm or a sterile probe cover, using sterile gel, and wearing gloves to protect both yourself and the patient, although there's no specific recommendation requiring sterile gloves. And then ultimately the probe should be cleaned both before and after the procedure using disinfectant wipes. And I want to take a moment just to remind you that the gray top wipes are the only ones that are safe for our machines, and so please do use those exclusively on the ultrasounds, and try to save those wipes just for the ultrasound so they don't get used up on other applications. For those of you who may be less familiar with our ultrasound equipment, this is our Sonosite export machine. We have two in the department, and for ultrasound guided peripheral IVs, we should be using the high frequency linear probe, which is this one with the rectangular footprint, the portion that contacts the patient's body, and it gives us a nice rectangular image. So to select that transducer, we'll have you hit select transducer and exam type, and then pick the linear probe, which is listed as L25. The L stands for linear, and the 25 is the 25 millimeters of length on it. And you can scroll down to select either venous or superficial as your exam type, which will optimize the image for you. So when you select the high frequency linear probe, it gives you this rectangular image. And here we're looking at a blood vessel in cross section, in which it appears round and dark or hypoechoic. And you can look at it either in that transverse plane, or you could also visualize it by turning the probe 90 degrees to look at it in the long axis. And either of these is an acceptable approach for performing peripheral IV access using ultrasound guidance. But for most novices, the short axis is an easier approach to learn. Each of these has some pros and cons. For the short axis, the pros will be that you can see both arteries and veins that might be side by side, and it's easier to see if you're moving to the left or the right. But it's a little bit more difficult to keep track of your needle tip, and you have dynamic movement in which you need to be moving both the needle and probe at the same time, which can be a little tricky. Conversely, the long axis, the pros of this approach are that you can visualize the entire needle along its course, but it can be surprisingly challenging to line up both the probe as well as the needle as well as the blood vessel all in their long axis. And it's easy to go out of the plane with either the needle going slightly to one side or the other, or also moving your probe to one side or the other. And so this ends up being a technique that takes a little bit more practice. So this video demonstrates typical positioning when visualizing a vessel running up the arm of a patient in first the short and then the long axis. So to help with your positioning, it's important to note this small little dot on the top left-hand side of the ultrasound machine, which corresponds to an indicator for the probe, which is a raised piece of plastic on one end of the probe. And essentially, if you're looking in the short axis of the vessel, you're going to be directing the probe indicator towards the patient's right-hand side, which if you're standing at the foot of their bed and placing an IV up back towards their heart, the screen left is going to be corresponding to your left side, but to the patient's right side. And with this, the important thing is that if you want to see more of what's on the left-hand side of the screen, you want it to be intuitive so that you're moving the probe towards the left side. And if you want to see more of what's on the right side of the screen, you move the probe towards the right side. So if you forget about the probe indicator, it's always possible to basically just touch some of the gel and see which side it corresponds to. So when trying to identify whether you're planning to access an artery or a vein, there's a few features that you can look for. For one, the veins tend to be very easily compressible, like this vessel on top. And you can see the vessel underneath it continues to pulsate even when the one on top is compressed. So the pulsatility is a characteristic of the arteries, as you would expect, and the arteries also tend to have thicker walls. Another technique you can use to try and identify whether something is an artery or a vein is by using the color Doppler, which can be found near the bottom left-hand side of the screen. And that's a setting that's as opposed to our normal 2D setting, which you can press if you need to get back to it. So in this color Doppler setting, you can see how the bottom vessel, which is the deeper vessel, has a brighter, more pulsatile flow, which corresponds to the artery, whereas the vein above it has slower flow. And it's important to note that the colors that we're seeing here don't actually correspond to arterial versus venous flow to determine the color that shows up on the screen. Really, it's just the direction of the flow, so that could get easily mixed up. So don't rely on that, but do look for that pulsatility. Using the color Doppler setting, you can also use a technique called augmentation to try and identify veins versus arteries, and this involves squeezing the arm distal to the vessel that you're looking at and looking for backflow in it. So you can see when it's squeezed here, that top superficial vein gets increased flow there. So in terms of potential targets, the upper arm is a nice place to look because they tend to be there and be less often used, so they tend to be in pretty good shape. But it's worth noting that the anatomy of the venous system is really highly variable throughout the body, so you can't necessarily rely on finding these named vessels, but just about anything that's relatively large and superficial is fair game. And by large, we mean typically at least 3 to 4 millimeters in diameter, which I'll show you how to identify that once we get to looking at depth on the screen. And as you know, EJs tend to be pretty popular targets as well. But at our institution, my understanding is that they prefer that the physicians go after these as opposed to the nurses, which is pretty silly given how much better you guys are at doing IVs than we are. So a few tips for success when trying to identify vessels. A nice place to start is at that AC fossa where they tend to converge, and oftentimes you can find paired artery and veins, and then can track the veins up or down to look at where they separate a little bit from the artery so that you don't have to be trying to poke at them where they're right overlying it. Sometimes just applying minimal pressure can cause those veins to collapse, so oftentimes if you just release a little bit of pressure on the probe, you'll actually see veins open up. And as I mentioned, you want to look for larger, more superficial targets. And then you can follow the course of the vessel or even look at it in its long axis to try and identify what direction it's heading so that you can try and plot the direction of your needle accordingly. When you look at the touch screen on our ultrasound machine, you can see these hash marks on the right-hand side, which correspond to the depth of your image. So by dragging it or just by clicking on a different hash mark, you can adjust the image to essentially sort of zoom in or out. So here on the left-hand side, we're initially at 3.8 centimeters of total depth and then have changed it to just 2 centimeters of depth. So in terms of your image, initially on the left-hand side, you can see here we're looking deeper, and that vessel that's pretty superficial looks pretty small on the screen. And by decreasing our depth to just 2 centimeters, it gives us a little bit larger target to work with on the screen. And then you can see how they mark along that right-hand side of the screen with the hash marks. 1, 2, 3 correspond to the number of centimeters that you're at, and those smaller hash marks correspond to half centimeter marks. So with that, you can see roughly what constitutes a half a centimeter and see that this vessel is roughly about 3 millimeters or so in diameter. So once you've identified that vein, then you want to get it in the center of the screen in the transverse axis, that short axis. And you might consider using what's called the needle guide to help you kind of maintain it in the center of the screen so that you know that's right where you're going. And you can see that button on the lower right-hand side of the touch screen. And when you click it, it appears with these white dots down the middle of the screen, which you'll see both on the touch screen, as well as you can see how they now show up on the screen itself. And that'll tell you exactly where the center of the probe is, which will help you in terms of maintaining your needle in the center of the probe as well. So just in terms of holding the probe, it's helpful to really make sure that you're able to stabilize it against the patient. So I tend to hold it with 3 or 4 fingers, and then make sure that you have your small and pinky finger available to help stabilize it against the patient's skin so that it's really steady. So once your probe is in place over the vessel and you're looking at it in the short axis, you need to decide how far away from the probe you should be entering the skin with your needle in order to hit the vessel right under the probe so that you'll see it on the screen. So this can be a little bit difficult to conceptualize, but if you think back to geometry and those isosceles triangles, which had 45-degree angles and equidistant sides, it helps in terms of figuring out how far away from the probe you should be entering the skin. So if you're going in at a 45-degree angle, you want to enter the skin the same distance away from the probe as the vessel is deep. And with that, you should hit the vessel directly under the probe. So if, for instance, it's 1 centimeter deep, to the center of the vessel, you would want to enter the skin about 1 centimeter away from the center of the probe. And you have to keep in mind that the ultrasound beam that comes out from the probe is pretty narrow. So if the probe itself is, maybe 4 millimeters wide, you need to take into account that about 2 millimeters or so on either side are right under the probe. So then you might go back about 8 millimeters or so. So if you're entering the skin at a shallower angle than 45 degrees, which we often want to do to be able to successfully cannulate these so we're not making a steep turn into the vessel, then you do need to back it up accordingly. So you don't have to measure this every time, but it'll give you a sense for roughly, where you should be entering in order to hit the vessel. So ideally, the goal would be to hit it right under the center of the probe, so that your needle tip shows up as this bright white dot, which we call hyperechoic, as opposed to hypoechoic, which is the dark color of the vessel itself. So to do this, you can use this sliding technique in which you inch the probe back towards your needle tip until you're able to visualize the needle tip. But you need to be aware that this can be a little bit tricky. So one pitfall of this is that the probe is going to see any piece of metal under it, whether it's the tip of the needle or just part of the shaft, in a pretty similar way on the screen. It's both just going to look like a bright white dot. So you have to be very cautious and really keep track of your needle tip. Another technique in addition to that sort of sliding inchworm technique is this fanning technique, in which rather than sliding the probe, you angle it back towards the needle until your needle tip appears. And either way, as I said, the key is to keep track of your needle tip. So using that short axis inchworm technique, here we're moving both the probe and the needle bit by bit, keeping track of the needle tip until we ultimately see it enter the vessel. And with that, you get two types of sensory confirmation. You both can see the flash of blood in your needle, as well as see the needle tip in the vessel on the ultrasound. And it takes some practice getting used to keeping track of both what's on the screen and also what's happening in your hands. But with time, it does become a little bit easier to keep track of both at the same time, just as when you're driving and able to look in the rearview mirror as well as sort of keep track of what's going on the road ahead of you. So with regards to catheter choice, the goal is to have at least half of the catheter inside the vessel so that it doesn't pop out. And so this is part of why we want to get pretty superficial vessels when possible. And for our typical IVs, the 20 gauges are 25 millimeters long, or 2.5 centimeters, and the 18 gauges are a little bit longer than that, 32 millimeters. So still, these aren't super long when we're starting to go after these pretty deep vessels in the upper arm in these edematous or obese patients. So we do have these angiocaths available that are a little bit longer, and the ones that we stock are 20 gauge catheters that are 48 millimeters, so almost 5 centimeters in length. And you can see the difference here between our typical catheter, the 20 gauge, with this longer 20 gauge catheter. And you'll notice that the longer IV catheter just has that retracting needle tip and lacks the phalanges of our typical IV catheters, so that makes it a little bit trickier to secure. So once you do get that flash, in order to secure it, you may want to add on this additional little piece of IV tubing, sometimes referred to as a J-loop, and that will give you a little bit more material to work with in terms of securing the IV. We did touch on the fact that there's also a long axis view which can be used, and you can see here what a beautiful shot you can get when you do directly visualize the entire needle entering the vessel. And so it's tempting to think that this would be, a much easier technique to use since you're able to keep track of them both at the same time. But the really tricky thing is, as I touched on earlier, is that to get this view, you need to be able to line up not only the vessel and the needle, but also the probe. And it's very easy to just veer off a little bit to one side with the needle, and suddenly it's no longer in the plane. Or even to move the probe itself a little, and suddenly you're not able to see the targets. So for most people starting out, I would recommend using that short axis approach, and then as you get more comfortable, you might eventually start trying this long axis approach as well. To highlight a few tips for success with this technique, as always, you do want to apply a tourniquet to maximize your targets. Again, you want to use the longer catheters when possible, especially for deeper vessels. You want to apply as little pressure as possible so that you're not compressing the vein any more than you need to visualize it. And then you can start by looking for those arteries that might be nearby, as they can be a little bit easier to identify, and then look for nearby relatively large and superficial veins. And once you get that flash, drop the angle of your needle as you're advancing it, and try to watch your needle tip advance a little bit inside that vessel to make sure that you're staying inside it as the catheter advances into the needle. So in summary, ultrasound guidance is helpful for a variety of patients who might have difficult IV access. Remember to protect yourself and the patient by using a sterile probe cover and sterile gel when possible. And again, you always want to look for these big, shallow targets. You want to try to confirm that it's a vein versus an artery, and that it's going to be easily compressible. It's not going to be pulsatile like the artery, and you might see that lack of pulsatility on the color flow, as well as using that augmentation technique to see the backflow into the vein. And then, as always, you want to use a longer catheter when possible. And I'd recommend mastering that short axis approach first, always keeping track of your needle tip. And then as you get more comfortable, I hope that you might at some point also give that long axis technique an attempt as well. So we as the ultrasound faculty here are always available to help answer questions regarding the use of ultrasound and placing ultrasound-guided peripheral IVs, so don't hesitate to ask us if you have any questions or concerns. Thanks for your time, and we'll see you in the sim lab for the hands-on portion.